this is just kind of showing you the different types of insulin and their onset, peak, and duration. There's also a good table in your book on page 754, it's 12-4, that has the same information on there for you. All right, there was supposed to be a slide on NPH insulin, so I'm just going to go ahead and just talk about those. But these are intermittent or long-acting type insulins. They are zinc and protamine that is added to prolong the action of the insulin. These preparations appear cloudy when they are properly mixed, and they recommend just rolling those back and forth in your hands. Do not shake these insulins, because that can cause them to put bubbles in there. Insulin, Gargulin is also known as Lantus. This is a 24-hour long-acting recombinant DNA human insulin analog. It can be given once or twice a day. Usually it's given at bedtime. It has a constant effect with no peak time. It can be used to treat both types of insulin, type 1 and type 2. It is not used or recommended for use in pregnancy and should not be mixed with other insulin types. All right, insulin is dispensed as 100 units per milliliter, which is the standard. It can also be 500 units per milliliter, and those are usually only used in rare cases of insulin resistance. Insulin does require a prescription. Nursing implications: all insulins are given parenterally. They are given subcutaneously. Rapid is the only one that can be given IV. Rapid-acting insulins are used in continuous subcutaneous insulin infusion devices, and so these are your insulin pumps. So this is looking at the glucose, continuous glucose monitor. And so this is basically the one that is telling you what the blood glucose is. And so it actually continuously records their glucose level, as well as being able to inject insulin. This is an insulin pen that a lot of people can use, and they just dial to the number of units that they want. And then it has a needle in there that they can use to actually inject the insulin subcutaneously. And this is another insulin pump that can be used, and it's just showing you most of the time these are always worn on the abdomen, and they can load the insulin into it and program it to inject a continuous amount of insulin. And they can also give bolus doses if they need to through these insulin pumps. And so this again is just kind of showing you the whole dynamic process of insulin pump therapy. And again, just showing you insulin pump, and then this is one that actually has a continuous glucose monitoring as well. So some of them only have parts A and B, and then some of them have the continuous glucose monitoring as well. All right, and this is just one type. It's called an Omnipod. And then this is another type called Animus. And then again, another type called Medtronic. And you can see they're all pretty similar. And then this one, they are using it in the subcu tissue of the back of the arm. And then it can also be used in the stomach as well. All right, look at insulin with type 2 diabetics. It is used when they cannot be managed with oral medications, or when they're hospitalized because of risk of hypoglycemia, when they're not eating and they have a slow response of medications to hyperglycemia. So a lot of times what they do is they may not give them oral medications at all and just cover them with sliding scale insulin. And usually they'll just use like a rapid acting or a very rapid acting type insulin. ICU patients, they use insulin for because they have less morbidity with intensive insulin therapy. Maintaining normal blood glucose during hospitalization decreases the risk of postoperative infections and shortens the hospital stay. IV insulins are preferred to maintain normal blood glucose levels. It does require frequent monitoring of their blood glucose levels and the insulin infusion as well. Pumps allow more normal regulation of blood glucose. It provides greater lifestyle flexibility. Needle site must be kept clean. It is changed every 2 to 3 days to prevent inflammation and infection. There are special injection products for those with physical handicaps. They have auto injectors, jet spray injectors, pre-filled syringes for visually impaired or traveling clients. The pre-filled syringes are stable up to 30 days if stored in the refrigerator. Vials can be stored at room temperature up to 4 weeks. If they have extra vials, they should be kept in the refrigerator and brought to room temperature before administration. Regular insulin requires no mixing. If it's cloudy or discolored, it needs to be discarded. Other types require gentle rolling between the hands, no shaking because that causes bubbles, and that could cause an inaccurate dose. You don't want any bubbles in an insulin syringe because even a small one can display several units of insulin, which means that they will not be getting the correct dose. These are some infections that you may see with pump sites, and a lot of this is because they did not rotate the site or they did not change the needle every 2 to 3 days and kept it really clean. They do recommend rotating the sites. Do not massage the site after injection. This will interfere with the absorption. Pressure can be applied for up to 1 minute if needed, and this is a gentle pressure. Techniques for minimizing painful injections are going to be to bring the insulin to room temperature before injection. Do not inject any air bubbles. Let the alcohol dry on the skin before injecting the insulin, making sure they relax the muscles in that area. Penetrate the skin quickly with the needle. Do not change direction of the needle during insertion or removal of the needle. And do not reuse a dull needle. A couple of things that can happen with insulin is lipodystrophy, which is hypertrophy of the subcutaneous tissue. This can also be caused by using a refrigerated insulin without letting it warm to room temperature. Lipoatrophy is atrophy of the subcutaneous tissue. Either can result when the same injection site is used repeatedly without rotating it. This is especially found with pork and beef insulins. It rarely occurs with human insulins. Tissues will become hard with an orange peel type appearance. Both cause alteration in insulin absorption. Basically, it delays the absorption of the insulin. Lipodystrophy usually resolve if the area is unused for a minimum of 6 months. The recommended site for sub-Q insulin is the abdomen because it has the most rapid absorption. so it's usually the recommended site. But they do not recommend injecting a site that will be exercised, like don't inject the thigh if they're fixing to go on a vigorous walk, or do not inject a site that has heat in it, or if heat is going to be applied to that area. Exercise and heat both increase the rate of absorption and cause a more rapid onset and peak of the insulin. All right, so this is showing you the different subcutaneous injection sites of insulin. Hypoglycemic agents, these are used in type 2 diabetics. They are used to lower the blood sugar by stimulating or increasing insulin secretion. Prevents breakdown of glycogen to glucose and increases peripheral uptake of glucose by making the cells less resistant to insulin. These are oral preparations, so they're taken orally. They do have injectable ones that is sub-Q, that's your Byetta. There's also one called Victoza, and they help stimulate insulin secretion from pancreatic beta cells, leads to a decreased hepatic glycogenesis, slowed gastric emptying, and increased satiety. Aspirin therapy, it's recommended once a day dose of 81 to 325 milligrams of enteric-coated to reduce the risk of atherosclerosis. Individuals with diabetes are up to 4 times more likely to die from cardiovascular disease. So aspirin therapy is given, but aspirin therapy is contraindicated, of course, if they have an aspirin allergy, if they have a bleeding tendency, they have anticoagulable therapy, any recent GI bleeding, or active liver disease. All right, looking at nutrition. Management of diabetes requires careful balance between intake of nutrients and the expenditure of energy and the dose and timing of medications, whether this be insulin or or anti-diabetic agents. Your ADA guidelines maintain a near normal glucose level by balancing food intake with insulin or oral glucose medications. Achieve optimal serum lipid levels. Provide adequate calories to maintain or attain reasonable weight or to recover from a catabolic illness. Preventing and treating complications of insulin treated diabetics. This could be from short-term illnesses, exercise-related problems, or long-term complications of diabetes. Improving the overall health through optimal nutrition using dietary guidelines for Americans. That is one example, and then Choose My Plate is another example that they can use to help with optimal nutrition. All right, carbohydrate intake can be individualized to the patient's needs with recommended allowances of, usually carbohydrates consist of 45 to 65% of the daily diet. Carbohydrates do contain 4 kilocalories per gram, and intake should be limited to less than 130 grams a day. Your plant foods, this would be from grains, fruits, and vegetables, milk, and some dairy. Your sucrose must be substituted for other carbohydrates, gram for gram. So if they choose to intake some sucrose, they have to adjust the carbohydrate intake. All right, protein intake. Protein has 4 kilocalories per gram. It is recommended 15 to 20% total kilocalorie intake of proteins per day. Sources should be low in fat, cholesterol, and saturated fats. This amount is lower than most individuals consume, and it's recommended to help prevent or delay renal complications. Dietary fats. Fats have 9 kilocalories per gram. Your dietary fats should be low in saturated fats and cholesterol. Saturated fats should be less than 7% of the total kilocalories per day, with cholesterol less than 200 milligrams per day. Sources of fat include saturated fat, polyunsaturated fats, and monosaturated fat. Sources of each of these: your saturated fats, animal meats, meat and butter, lard and bacon, cocoa butter, coconut oil, palm oil, and hydrogenated oils. Your polyunsaturated fats, your sources of oils of corn, safflower, sunflower, soybean, sesame seed, and cottonseed. Your monosaturated is peanut oil, olive oil, and canola oil. Dietary fiber is helpful in treating or preventing constipation and other GI disorders, including colon cancer. It is recommended to get 20 to 35 grams a day. There's two different types of fiber. You have a soluble fiber, which is found in dried beans, oats, barley, some of your vegetables and fruits like peas, corn, zucchini, cauliflower, broccoli, prunes, pears, apples, bananas. Your insoluble fiber, this would be wheat and corn, some of your vegetables and fruits to include carrots, Brussels sprouts, eggplants, green beans, pears, apples, strawberries. These will help facilitate GI motility and a feeling of fullness. It is recommended that limiting fats and cholesterol intake can help prevent or delay atherosclerosis onset. All right, looking at sodium. The body does require sodium, but most people consume much more than what is needed each day, especially in processed foods. So the recommended daily intake of sodium is 1,000 milligrams per 1,000 kilocalories, not to exceed 3,000 milligrams a day. Primary concern about sodium is hypertension. It is suggested that table salt, which is 40% sodium, and processed foods high in sodium be avoided in diabetes. When you're looking at the diabetic diet plan, you want to restrict the amount of refined sugars. As a result, they may use non-caloric sweeteners and foods and drinks made with non-caloric sweeteners. Your non-nutritional sweeteners should be used with caution. Examples of that would be your saccharin, which is found in Sweet and Low, aspartame, which is found in NutraSweet and Equal, sucralose, which is Splenda, and stevia, which is Truvia. Alcohol consumption is not encouraged, but not totally prohibited either. Alcohol consumption can potentiate the hypoglycemic effects of insulin and oral agents. Signs of intoxication and hypoglycemia can be similar, so type 1s are at risk for an insulin reaction. Light beer is recommended, is the recommended alcoholic drink. Liquor does have some sweeteners in it. So like your sweet wines, wine coolers, and sweet mixes contain large amounts of carbohydrates. So alcohol should be consumed with meals and included in the daily food intake. So a drink with 1.5 ounces is 2 fat exchanges. So if they choose to drink something, then that's going to take away from their other food that they can ingest. The meal planning should be individualized. There's lots of different meal plans out there. There's point systems, carbohydrate counting, calorie counting. There's different food group exchanges. There's food list, consistent carbohydrate is another one. Diabetic meal plan is another one. All right, sick day management. When individuals with diabetes are sick or have surgery, their glucose levels increase even though their food intake decreases. So clients may often omit their insulin dose because they think, well, they're not eating, so they don't need to take their insulin, which is quite the opposite. They usually need to go ahead and keep taking their insulin because of this rise in their glucose levels. So when they omit these doses, this causes further problems. So looking at the guidelines for sick day management, they need to monitor their blood glucose at least 4 times a day throughout the illness, test the urine for ketones if their blood glucose is greater than 240 milligrams per deciliter. They need to continue their normal insulin and hypoglycemic doses. Sip 8 to 12 ounces of fluid each hour. They need to substitute easily digested liquids or soft foods if solid foods are not tolerated. So these substituted foods and liquids should be carbohydrate equivalent. So an example, half a cup of sweetened gelatin, half a cup of fruit juice, 1 popsicle, 1/4 cup of sherbet, and 1/2 cup of a regular soft drink. They need to call the healthcare provider if they're unable to eat more than 24 hours or if their vomiting and diarrhea lasts greater than 6 hours. Exercise. Regular exercise improves physical fitness and emotional state. It also helps with weight control and improved work capacity. They need to avoid exercise in extremes of hot, cold, or during periods of poor glucose control. Another factor is time of exercise in relation to their meals and insulin injections and the time of day of the activity. Exercise increases the uptake of glucose by muscle cells, potentially reducing the need for insulin. Your type 1 has an increased risk for hypoglycemia and hyperglycemia. In type 2, exercise may decrease the need for oral hypoglycemic agents altogether. Surgery involves replacing or transplanting pancreatic cells, beta cells, or the entire pancreas. It is still under investigative measures, but believe that transplanting even just the tail of the pancreas is very promising in achieving long-term control of the disease. Surgery alters self-management and glycemic control. Hyperglycemia and protein stores are decreased. They're at high risk for post-op infections and delayed wound healing. They're at high risk for fluid and electrolyte imbalances, as well as hypoglycemia and DKA. And so all of these regular types of surgery do cause lots of changes in their blood glucose levels. All right, so preoperative screening for complications and their regular glucose needs to be done. Insulin dosing is individualized, may be given to type 2 diabetics and those with hyperglycemia but not diagnosed with diabetes. And that's what I was saying before, that a lot of times they'll be on that parental nutrition, and so they may end up having to get insulin. But all of this is going to be individualized to the specific needs of the individual. Oral hypoglycemic agents may be withheld for 1 to 2 days after surgery and during periods of the perioperative period. All right, your client with type 1 or type 2 diabetes with pre-glucose, with pre-op glucose. So basically when their NPO, short-acting insulin, shouldn't be given with IV glucose. Clients with type 1 or type 2 who are critically ill in the peri-op period should receive IV glucose and insulin infusion in an ICU setting because it can be closely monitored and the insulin infusion can be titrated. And the ICU settings are about the only ones that will titrate an insulin drip. They will try to schedule the surgery procedure as early in the morning as possible to minimize the length of fasting for these patients. Post-operative care, regular glucose monitoring is important. Stress can increase insulin requirements. So they really need to watch for signs of hypoglycemia as well when they're giving them this extra insulin. If no food intake after surgery, IV dextrose can be given with sub-Q insulin every 6 hours in your non-critically ill patients. Target blood glucose during surgery is 110 to 140 milligrams per deciliter, and that helps to prevent hypoglycemia, which is difficult to detect when a patient is under anesthesia, and it prevents glycosuria, dehydration, and impaired wound healing. All right, looking at the nursing process. Assessments, planning, implementation differ for clients with newly diagnosed diabetes, clients with long-term diabetes, and with clients with acute complications of diabetes. There are 3 levels of client teaching according to the ADA. Teaching patient and family to self-manage diabetes is a nursing responsibility, even if formal teaching plan is developed by an advanced practice nurse. The information must be reinforced by the nurse and must be done for newly diagnosed patients as well as those who've had diabetes for many years. So survival skills are basic knowledge and skills in diabetes management for the first 1 to 2 weeks while getting used to the idea of having diabetes. Home management emphasizes self-reliance and independence of daily diabetic management. Improving lifestyle and educating clients to individualize self-management of the illness. Health promotion activities will focus on preventing complications of diabetes. You want to also teach them to prevent or decrease excessive weight, follow a sensible and well-balanced diet, and maintain regular physical exercise program. Looking at assessment, looking at health history, you want to find out if there is a family history of diabetes. Do they have a history of hypertension or other cardiovascular problems? History of dizziness, numbness and tingling of their hands and feet? Any changes in vision or speech? Do they have pain when walking? Changes in weight, blurred vision, appetite, frequent infections, slowed healing, frequent voiding, problems with any GI function or urination. Also ask them about altered sexual function. In the physical assessment, you want to get a height-weight ratio, obtain vital signs, visual acuity, also assess their cranial nerves, sensory ability in the extremities. So you're looking at touch. Can they differentiate between hot and cold? Can they feel vibrations? You want to assess peripheral pulses, looking at skin and mucous membranes. You're also looking at hair loss, looking at the appearance of the skin and mucous membranes, any lesions found, any rashes or itching, also any vaginal discharge. Older adults are aware of normal aging changes in all body systems, may alter their interpretation of findings. Children are generally admitted at the time of diagnosis. You want to assess their physiologic status, and that's going to be through checking vital signs and their level of consciousness. Hydration, you want to look at mucous membranes, their skin turgor, urinary output. Blood initially is checked every hour to monitor blood gases and glucose and electrolyte levels. Once they are stable, you want to assess dietary and caloric intake. Again, with children, assessing the family and their coping mechanisms, looking at their family resources, strengths, their ability to manage the disease, also looking at their educational needs of both the child and the parent. We'll talk about more in detail with kids and diabetics in the next Camtasia. This is a list of your NANDA diagnosis for diabetes. Planning goals may include that the client describes how to administer medications and and how they respond to the different side effects. They need to be able to describe strategies for reducing the risk of infection. Client can demonstrate meal planning compliant with the ADA, proper foot care and inspection, proper procedure for monitoring blood glucose levels, implementation, individualized education about normal metabolism, diabetes and how diabetes changes the metabolism, how the diet helps keep blood glucose within normal limits, number of kilocalories that are required and why. And so they're looking at the amount of carbohydrates, meats, and fats. They're looking at why the kilocalories are different for these, how to calculate the diet while integrating personal food preferences. They need to learn how exercise helps lower blood glucose. They also need to know the importance of having regular exercise program, different types of exercises, and how to handle that increased activity as far as their blood glucose monitoring. Self-monitoring of blood glucose, how to care for the equipment, what to do about increased or decreased levels of blood sugar. Medications. This could be insulin, IV, sub-Q agents. They need to know the different types, dosage, how to mix them, just instructions on the care of their insulins, time of onset, peak actions, the equipment care, injection sites, rotating the sites. Your oral agents, they need to know the different types, dosages, the side effects of them, interactions with other medications, manifestations of acute complications. And this will be hypoglycemia, hyperglycemia, and what to do for each one of those. They need individualized education about hygiene, including skin care, dental care, feet care, sick day management, and what to do about food, fluids, and medications. Provide them with helpful resources. There's all kinds of resources out there for diabetics. They need to adapt teaching to special needs or the development level of the child or the older adult. All right, looking at their skin integrity, patients with diabetes, they're at increased risk for altered skin integrity due to decreased tissue perfusion from cardiovascular complications, infections, and decreased or absent sensation from the neuropathies like we talked about. Baseline and ongoing assessments of the feet need to be done. Gangrene of the feet and decreased blood flow with of the lower extremities as well is very common. Musculoskeletal assessment includes the foot and ankle range of motion, bone abnormalities such as bunions, hammer toes, overlapping digits. All of those can cause alterations in their skin integrity. Looking at their gait patterns, use of assistive devices for walking. Neurologic assessment includes sensation of touch, position, pain, and temperature of the extremities. Vascular examination, lower extremity pulses, capillary refill, color and temperature of the skin, any edema present. Assessment of hydration status includes dryness or excessive perspiration. Need to assess for lesions. They need to look between the toes for fissures. Look for any corns, calluses, plantar warts, ingrown toenails or overgrowth of their toenails, redness over pressure points, blisters, cellulitis, gangrene, peripheral neuropathies, and vascular disease. Your peripheral neuropathy can cause alterations in perception of pain, loss of their deep tendon reflexes, foot drop, changes in the foot shape, changes in bones and joints. Peripheral vascular disease. This includes your intermittent claudication, absent pulses, delayed venous filling on elevation, dependent rubor, and gangrene. You want to teach foot hygiene. They need to wash and inspect their feet daily. They use just regular soap and water. They need to pat dry their feet and between their toes. Smoking cessation. Nicotine does cause vasoconstriction, which decreases the blood supply to the feet. Maintain their blood glucose in normal levels. Hyperglycemia promotes microorganism growth. Conducting foot care teaching sessions is a priority in diabetics. Promoting healthy behaviors. You want to use and teach meticulous hand washing. That is the number one thing that you can do to help prevent the spread of infection. Monitor for manifestations of infection such as increased temperature, pain, malaise, swelling, redness, discharge from the area, cough. Discuss the importance of skin care. They need to use lukewarm water and a mild soap. Teach dental health measures. They need frequent checkups, oral hygiene, and good dental hygiene. You want to teach women the symptoms and preventative measures for Candida albicans. So basically this is an odorless white or yellow cheese-like vaginal discharge that may have associated itching. Diabetes does predispose them for the development of Candida albicans vaginitis, and so that's one of the reasons why you're asking about a vaginal discharge. Some women will come in and that will be their complaint, is that they have a yeast infection, and if you check their blood sugar is really high and they don't even know that they're a diabetic. Poor personal hygiene and clothing that keeps the vaginal area warm and moist increases the risk of vaginitis. The infection can spread to the urinary tract and result in a UTI. So preventing and treating vaginitis will help decrease the risk of UTI development. All right, maintaining safety. They are, you want to try to decrease the risk of injury. So assessing for the presence of contributing or causative factors that may increase their injury risk, like blurred vision, cataracts, decreased adaptation to the dark. So maybe they have that slow pupil dilation in the dark like we talked about earlier. They have decreased tactile sensitivity, hypo or hyperglycemia, hypovolemia from dehydration, joint immobility and an unsteady gait. You want to help reduce environmental hazards in healthcare as well as the home and community settings. You want to monitor for and teach both the client and the family to recognize and seek care for manifestations of DKA with type 1 diabetes, HHS in clients with type 2 diabetes, signs and symptoms and treatment of hypoglycemia. And again, on page 763 has the symptoms of all of these in your book. It is recommended that they wear a medical alert jewelry, whether that be a bracelet or a necklace. And that's because if somebody comes on the scene and they are not able to respond, then they will know that they're a diabetic. And so this is just basically telling, this is the kind of jewelry and what it would tell first responders. All right. They do have changes in sexual function and sexuality have been identified for both men and women with diabetes. So trying to help maintain their sexual health involves not only physical activities, but also their self-perception. You want to include their sexual history as part of the initial and ongoing assessment, providing information about actual potential physical effects of diabetes on their sexual function. Changes in their blood glucose levels can cause changes in their desire and physical response, as well as may alter sexual responses as a result of depression, anxiety, and fatigue of just having the disease itself. You want to provide counseling and make referrals as appropriate. And promoting effective coping. Clients that are diagnosed with diabetes face lifelong changes. They have to have a new diet. A lot of times they are on new medications. New exercise and other habits have to be followed. To determine how well the patient is coping, you want to assess their psychosocial resources, looking at emotional resources. Do they have good support systems? You're also looking at finances, changes in their lifestyle, their communication skills as well. You want to explore with the client and the family the effects, which could be actual or perceived, of the diagnosis, treatment, the effects on their occupation, energy levels, relationships, as well as finances. You want to teach constructive problem solving and techniques, provide information about support groups and resources. Looking at evaluation. Expected outcomes can include client demonstrates age-appropriate understanding of diabetes. This includes self-management through medication, exercise, diet, as well as blood glucose self-monitoring. Client's skin integrity should remain intact. Clients will remain free of infection, and they will also remain free of injury. So this is the end of diabetes. Mainly this was for adults. And again, if you have questions, let me know and we will try to help clarify things.